come to this community of practice meeting. Thank you.
Thanks, Daisy. Well constructed, very thoughtful case. Thank you for your time and presenting it to us. So what we'll do now is we'll move over to case number 2, which is going to be shared by Nina, and then if we can just zoom right in again. Thank you.
Awesome, thank you. So this is a bit of a unique case. When I was approached to present a case, it was mentioned that I could pick a patient who might be struggling through this pandemic or doing really well through this pandemic. So this is a bit of a mix. And I also have another clinician on this call, Lori Madison, who works close with me with this patient. So she's also here to answer any questions that might come up. So a little bit about this patient. She's a 30-year-old female who participates in our medication-assisted treatment program here at Muskeg. She does have a few co-occurring mental health disorders, as you can see. She last reported her last use of opiates was back in February, so she's been doing very well on that end. She does use marijuana daily, that she reports. She has a 9-year-old daughter who lives with her half the time. Her daughter lives with her father half the time as well. She lives in an apartment with her brother and a close friend who both have history of substance use disorders. And she reports that her brother is actively using substances, so that has been a stressor for her. So back in early February when she had a reoccurrence on opiates, she had mentioned that a lot of times her history of reoccurrences occur when she has a lot of difficulty with emotional regulation. So as a team, we had discussed what might be the best modality to support her. So we talked to this patient about DBT, and she was very open to this. So on top of participating in weekly talk therapy with me, she has also been participating in weekly DBT skills training with Lori. And she has also been actively participating in medication management with our psych NP here at Muskeg as well. So as part, or at the start of the pandemic, the patient and her partner had separated. She had been with her partner for about 2 years. She described this relationship as very toxic. There were many domestic violence situations that occurred. There were many times that she came in the office with bruises on her that I had noted. So there was a long history with this ex-partner. So they actually ended their relationship right when the pandemic started. She lost both of her serving jobs, but successfully was able to apply for unemployment. So through this pandemic, she's been actively participating in these telehealth services with myself and Lori, but she has voiced much difficulty with the coping of this ending of her relationship. Due to the isolation, due to the boredom at home, she has voiced increased cravings for opiates, but successfully, as she reports, she has been able to sustain sobriety from opiates, which has been great. And then, so one of the things that she's always mentioned to us too is that she really likes the accountability piece of having the UTOC screenings when she comes into the office before the pandemic happened. And because of the pandemic, she hasn't been able to do that. And so she has voiced a lot of difficulty in not having that accountability piece as well. So on top of not having the accountability piece, coping with this ending of the relationship, being isolated, being bored and whatnot, sounds like she's doing pretty well. She's introduced a lot of kind of self-love and self-help coping strategy books into her daily life to help cope with this breakup. She's actively participating in the counseling piece, as I mentioned. And from what she reports, she's been able to sustain her sobriety from opiates. So on one end, she's doing really well, but on the other end, she's having a lot of difficulty coping with this breakup through this pandemic. She frequently voices a lot of negative self-talk. She's extremely angry at herself for staying in the relationship as long as she did. So it seems like she's very stuck in this one spot, and we're trying to support her on different strategies or different resources, approaches on how we can help her best cope with this with the pandemic. So those are my 2 questions. If anyone has any suggestions on other strategies that we could try with this patient in the midst of this pandemic, and then if there are any strategies to help normalize this patient taking responsibility for her sobriety without having the accountability of the UTOC screening, if that makes sense. So kind of unique, as I said, but any type of suggestions or resources or anything would definitely help.
Thanks, Nina. As I will give people a chance to write in and raise their hand, and we're looking. We have Shannon with a hand raise.
Hi, yes. Hi, Nina. That was,
Hi.
thank you for sharing that case. Just in thinking about the strategies for the accountability and the urine tox screening, are you guys not having people come into the office right now to be able to do that? Is that what you said? I'm sorry.
Our protocol is we're not unless we feel the need to. So if there's any concern with diversion or anything like that, we can have them come into the office. But for our patients who we feel like are doing really well, we don't have them come in.
Is there a possibility of ordering the labs and maybe having them go to like a Quest or a LabCorp, like external lab, and so that they're not having to come into the office necessarily, but you're still able to get those testing results done and maybe set up some sort of a regular schedule with the client? I mean, I don't know how that might affect like costs or insurance fees, but just, I don't know, just kind of throwing some ideas out there.
So if this patient did voice to us, I really want to come in for a urine screening, we could do that. We could offer that for her, and she could. I guess my question is how we can best support her and how to try to normalize this for her, and not focus so much on the urine screening and focus on that she is doing really well, and she doesn't need that concrete evidence to say, hey, you are doing really well. So, but she could come in if she wanted to.
Okay, gotcha.
Mm-hmm.
Nina, we had someone write in, what about an online support group for people who are grieving the end of a long-term relationship?
Yeah, I do know that this patient has been actively involved with online NA groups in the past. So I think she would definitely be open to anything online. I didn't think of the grieving to the end of a long relationship type of group though. So that could definitely be something that I suggest.
Jennifer, do you want to add more?
Sure. So I was thinking a little bit about the urine screens and how that provides accountability for your patient, which it does with many. It's really great that she recognizes how that helps her. I mean, she has that insight. I wonder if this might be a good opportunity to work with her about identifying what the thoughts, feelings, and what her process is around that accountability piece, for her to be able to kind of identify that and see if in identifying those pieces, she can create her own accountability, something different that will help keep her on task. The idea of urine screens are external accountability, and this could actually be a really good opportunity to help her transition that to an internal accountability piece. I wonder if that might, if that might be a helpful thing in counseling, or to help her with counseling.
Yeah, no, I do like that idea. Do you have any experience in doing that with anyone, or?
I mean, not specifically with U screens, but in terms of kind of transitioning that, a little bit using motivational interviewing. You're helping her identify her goals and kind of getting in her place and trying to help her then identify the steps that she needs, or that would more closely align with what her goals and what she identifies as her needs are. This was on the fly, so I'm not thinking of anything off the top of my head, but there are ways that you might be able to utilize her skills in DBT to also kind of bolster getting to that place.
Yeah, no, I think that's a great idea. So really just supporting her and transitioning from more of the external accountability to the internal accountability.
Yeah.
Awesome. Thank you.
whenever I go to internal accountability, you know, I tend to focus on, you know, supportive thoughts, supportive feelings, and body sensations, right? So
Okay.
like breaking down how feeling good feels good, you know,
Mm-hmm.
and I hit those different levels. So that way, you know, she's kind of creating her own sense of what good is without it being quite so vague and nebulous. You know, she's trying to make it concrete.
Sure. Sure. I like that idea. Thank you.
Thanks, Jennifer. Nina, we had a couple of things coming in the chat. So one is a link that we'll save and disseminate back out. But Anne-Marie sharing that this is a handout we use in our practice, not specifically about the grief of a long-term relationship, but certainly some action steps. It's called How to Move On After Ending a Long-Term Relationship that they have some success using. Anne-Marie, can you talk a little bit about how people respond to that resource? Does it seem supportive to them and that they react well to it, or?
They really do react well to it. They do find that it's helpful. They often will refer back to it during subsequent appointments. And I mean, we've certainly had some people sort of, you know, toss it in the file, circular file on the way out of the visit. But for the most part, the people who spend time looking at it, they really do find that it's helpful.
Great.
That's awesome. And you mentioned that will be sent out. So
Yep.
Awesome. Great.
We have it in the chat, and so we'll make sure to save it for you and put it in the kind of Q&A document that we'll make.
Great.
We have a question from Mary asking if anyone is using oral swabs at home. She's seen it mentioned multiple times in multiple webinars since we went to virtual to collect the sample on screen and then mail it in. Has anyone been using those in their practice or know of anyone that is using them?
I answered it beyond there, if you look down.
Oh, thanks, Molly. Would you mind reading or just kind of saying what you?
Yeah, so my understanding, and I really, I have talked to one doc, he's in Maine, and he has used telemedicine for a long time in his practice, way before COVID. And one of the things he does is exactly, he will mail them with a a return mailer. He'll mail them the oral fluid swab. It is not meant to be a point of care test, but he watches them do the test, and then he sends it, then they send it back to him, and he has the lab process it. So that, I believe, is CLIA waived. But if you are looking to do I've looked them up online, you can get swabs that somebody could just show, on the screen, look, it's negative for X, Y, and Z. That's not CLIA waived because it's not done in a lab, and it's not done by somebody who's been trained to do it. But what Mary is asking, and it gets sent back and then processed through a lab, that is, I'm pretty sure that would be okay. Now that my friend in Maine is in Maine, still we have to look at federal guidelines, which is a CLIA issue. So it should be okay. I've not done that. I've actually been having patients come in if I feel like I need to do a test for them. Either I'm seeing them in the office for one reason or another, or for example, I had a guy call today, actually while we were on this, and say that he lost his medicine. So I had my staff call him in and do an oral swab in the office. They're just certain things that I feel like it is important to continue. Generally, ASAM is saying to weigh the pros and cons for whether or not you're going to continue to do testing.
Thanks, Molly. Susan, I'm not sure if I am going to represent what I saw you chat in well. Would you mind sharing your thought verbally as well?
I think just since the patient seems so persistent about this, wanting the urine screen for accountability, and you would be able to do that, would it not kind of reinforce all the other positive decisions that she really is making right now? And then probably just wean her off of it. We're so happy that it came back negative. And, how do you feel about going for, 2 weeks or 3 weeks, and then just, so that you can tell it's not as critical for you as it is for her. But right now she may see that as really helpful support.
Sure. Yeah, definitely. And I definitely would be happy to offer that to her if she would like to come into the office, because I agree, kind of just more positives, if that's going to give
Yeah.
her, more of that positivity, I think that's great.
Right.
So if it comes to that point, definitely, I think we can offer her that.
Yeah, and then as Susan was mentioning, she has so many strengths in so many areas
Mhm.
that to, highlight and transfer those to the breakup to continued recovery that,
Mhm.
like, I feel like she's got the skills, she
She
just,
does.
yeah.
Yeah, she does.
Anne had a thought about connecting her to a peer recovery support worker. They often help people identify recovery goals and formulate a recovery plan. They collaborate and support people by providing accountability and strategies to continue to work on recovery goals. So maybe, now she's at the place that it's really recovery goals rather
Mhm.
than like more traditional treatment goals kind of thing. Has she been connected at all to peer recovery?
I wouldn't say too much. No, she's really more focused on coping with this breakup. So she's doing a lot of self-help and self-love books. So I don't think she's getting more of that peer support. I guess my question is, what are people's experiences right now with the pandemic with peer recovery support workers? What's kind of going on with that? Because we have CRSWs, but they're more prenatal based right now than anything. That's kind of their role. So I didn't know what other people had experiences with the peer recovery support workers right now.
Lindy, did you want to respond to that question?
Yeah. So all of the recovery community organizations are offering recovery coaching either virtually with Zoom or with an electronic platform of some sort, or by telephone, depending on what people had available.
Okay.
And they're all doing that during regular hours. Some are even offering more frequent. So if you go to nhrecoveryhub.org, find out where your local one is and click on their website, they'll tell you how to get in touch. A number of them actually have a chat button right on their website that you can click on, and someone will get in touch with them like right then.
Great. Okay.
They're all working toward that. I just don't know if they've all got the button on yet. I know that SOS does over on the Seacoast. They've been doing it, and I think theirs is almost 24/7.
Awesome.
So I think back even with I like the idea that Anne Marie had about the handouts, since she's working so well on self-help things anyway, and the DBT stuff, she's done the activities. It sounds like she applies stuff well. But if it really is sort of a grief kind of thing, I do think that some of the virtual meetings are grief related, and that's grief in a broad sense. So whether people have lost someone due to COVID or due to an overdose, or whether they've just, they've lost their job, or they've lost a partner, or they've lost, just their feelings of anything. Grief is a big part of stuff right now, and even more so with the, the whole Black Lives Matter thing and the trauma and institutional racism and all that. There's a lot of grief tied in there too. So I think it's a common shared feeling right now, and your support may be a good place for that. It sounds like this woman takes advantage of whatever you offer her.
I feel lucky in that sense. I think Lori can speak on behalf of that too, because a lot of the times I feel like I'm pulling teeth with patients to do those types of things. But yeah, she's super open to really trying anything. She's very hands-on. She loves to write. She actually shared a letter with me the other day that she wrote to her ex-partner, and that was extremely emotional for her to share with me. But yeah, she's super open to anything. So I would love to present this more recovery, peer-based things for her and see if she's open to that.
Well, based on what you just said, and you're at Amoskeag, right?
Yes.
So Hope is like the recovery center that does the most with arts. So
Yep.
both, visual arts, but also written arts. They have a lot of success with that kind of thing. So there's one more option for you to very specifically, you could call in advance and just talk to the director there and say, I'm looking for someone likes to write. What can they do? And I bet you'd get a good connection.
And are you aware of any updates about Hope right now, or what they're doing telehealth wise?
They're doing everything telehealth. They're very open to that. Their phone lines are open. More than 8 hours a day. I don't know the exact hours, but it's on their website. They've got people on call all the time. But again, I think, the director is the writer there. So you could call and ask to talk to Keith and just ask him about it.
Awesome. Yeah, I mean, not only for this patient, but Hope was a resource for many of our patients here at Amoskeag, and they were pretty bummed when they heard, they weren't doing the live groups or anything anymore. So to give them that resource, knowing that they can still get resources through telehealth, I think is awesome. So
they're also doing what they call guerrilla. That's like the GUER, guerrilla all recovery meetings at a local park outside.
Oh, okay.
And they are in discussion for when they're going to open, but they're really taking the social distancing and masking very seriously. They want to make sure that they can do that. They're going to do some recovery meetings in multiple rooms so they can get enough people and then have the electronic connection inside the building. Very interesting, creative solutions.
That's good to know. I'll have to call to find out when that outside park group is and let some of our patients know. So thank you.
Thanks, Lindy. That's great. I know that I had seen, I think from SOS, like the thousands of people that they were able to reach now through all of their remote groups that, like Lindy said, happening, it seems like at all hours of the day. I don't know what their staff are doing, but they seem to have really figured it out.
They've gotten people from 7 countries involved in groups.
Wow.
They've really expanded the idea of what recovery community looks like.
That's awesome.
Thanks so much. So Nina, do you think that, did we address both of your questions, or is there one that I should probe more on from the group?
No, I think everything was super helpful. So I really appreciate everyone's suggestions and whatnot. And I'm excited to take a look at that handout that was sent back and explore that a little bit more. Definitely get connected with Hope, and I'm really interested for myself on my own skills to help her explore more of the internal and the external accountability piece. So thank you all.
Any other last thoughts or suggestions for Nina? Okay. Oh, I forgot to check the chat. Someone said, great job, Nina.
Thank you, Kate. Thanks, guys.
Thank you. Thank you, everyone. So with that, I'll transition to our third case, which is going to come from Jennifer over at Weeks. So Hannah will get that one up, and I'll hand it over to Jennifer.
Thanks, Adelaide. So this case is about Janine. Of course, this is a pseudonym, and she is and I apologize for any typos. I kind of wrote this quickly. So she's a 25-year-old divorced woman who has a young son. He's 2 years old, who is currently in care, and DCYF is involved. So she was coming fairly regularly for treatment, group counseling, individual counseling, and MAT. And then right when the pandemic started, or at least when government services and government functions closed, she dropped off the map for services. And since she has returned, and she's returned within the last 2 weeks, she confirmed with us that the reason that she had dropped off the map was because she did relapse. And she relapsed because she had received notification that her court hearing for her son was canceled or postponed at least. And she, due to feeling hopeless, she relapsed with her now ex-boyfriend. and her relapse was on stimulants rather than opioids, which she is currently receiving MAT for. At the time, she was obtaining Suboxone on the street. So since her return to the clinic, and like I said, she returned approximately 2 weeks ago, our services have been as a hybrid. So there's, we maintain in-office appointments for the medication portion of MAT throughout the pandemic. So although occasionally we would bridge people or do Zoom appointments with a provider, they were coming in to have U-screens whenever they would have their, whenever they were up for their medications. So she has had both Zoom individual counseling and group Zoom appointments as options. So she has re-engaged. However, you know, it presents with a number of challenges, both that were existing before the pandemic and has been existing, you know, since the pandemic. So transportation is an issue for her. She's not currently employed either, nor was she prior to the pandemic. Connectivity is often an issue as she is currently homeless. You know, so engaging with services is often, you know, difficult for practical reasons, you know, in addition to where she is in her recovery, because she is also continuing to have slips, you know, as she's receiving services. So she's not stable, and not nearly as stable as she was prior to coming. You know, she's probably using stimulants at least a few times a week, but no longer daily. She's having a lot of difficulties with her relationship while her ex-boyfriend is now her ex. She is currently friends with him, and he's her primary source of transportation. So, and also currently using. And so, you know, that is a big stressor and very, very challenging for her, as he is her primary source of transportation to come to the clinic for her use screens and her appointments. So in general, connecting with resources has been very challenging for her. She has few natural supports, although when they are involved, they have been quite helpful for her. She responds well to counseling. You know, she's been able to develop a therapeutic relationship, you know, with me, although group counseling she has great difficulty with due to anxiety in a group setting. So my questions for the group, and I'm happy to answer any additional questions in regards to this individual too, if more information is helpful. Centers a lot around stimulant use. So in terms of effective interventions for patients using stimulants, I mean, this is both when pandemic is not going on, but also especially now, as you know, some of the methods that I know have been helpful have to do with like contingency management, which all the ways I can think of require coming into an office, being present. So any ideas there would be really helpful. And then, you know, the rest of the questions that you can definitely read. I saw a question from, I think, Peter about her boyfriend not being the father of her child. And no, he is not the father of her child. So that's just it in brief.
Thanks, Jennifer. Another very complex one with a lot of different parts. Are there other clarifying questions for Jennifer before we move in, or moving right into ideas and suggestions? We have the question that Jennifer mentioned on therapeutic interventions for using stimulants, pharmacological or therapeutic interventions, and then especially in the virtual context. Help clients develop sober supports, natural and resources with a stay-at-home order in effect, and then the resource and programmatic supports for transportation and communication. So we will open it up. So I know that stimulant use is a tough one, but we've got it in us, I'm sure, to come up with some good suggestions for Jennifer.
So I'm trying to go through, I have a Google group of a lot of addiction docs. And I do recall seeing a recent paper, I think it was in December. So I'll keep looking for it. But in general, one of the things I would discourage, because I get this question a lot, should I use Adderall? Is Adderall better than using, methamphetamine? And the answer is no, don't use it, because this is somebody who has addiction, and this is somebody who's going to use it compulsively, and it doesn't treat methamphetamine use disorder. It doesn't treat a stimulant use disorder. It's to be determined, I guess, if this woman has a stimulant use disorder per se. If she's been treated for an opioid use disorder, it's not a drop kick, absolute that she has a stimulant disorder, but the risks are pretty high, and chances are that, well, she does have one. So it's and if she's using methamphetamine, and which is a pretty dangerous substance, it's likely that she would fall into that category. So I discourage using Adderall as a treatment or substitute, because what will happen is she will use it compulsively, and it just kind of swirls it. It's the same reason we don't use Percocet for an opioid use disorder, because there's not an ability to control that. It doesn't do the same things to the brain as buprenorphine does in terms of its treatment ability, just the same as just the same as methadone. So I will, if I find the studies while we're going through this, I will post them.
Thank you, Molly. I can tell you that the provider that she's working with for medication is not considering Adderall at all, to help treat her. But I've heard people asking that before. I really appreciate you addressing that.
Molly, is the paper you're looking for speaking to therapeutic interventions for amphetamine, or other suggestions for more appropriate pharmacological?
As I recall, there, I want to review it, but it's looking to therapeutics, yeah, because obviously people are racing to try to find things, and there's not any, there really hasn't been an absolute finding like we have with bupe, but for opioids. But yeah, I remember reading them. They're just not at the top of my head. I have to reinvestigate.
Thank you. Others' experiences treating people using stimulants, especially in the remote setting?
I guess this was a good question to ask, because everyone's having a hard time with it.
Lindy, we have a hand raised.
Yeah, I'm not looking at the first question, because you're right, contingency management is effective, but I'm racking my brains in terms of how to do that remotely. But the other two, and something else, just the fact that this is stimulants and methamphetamine in particular, there has been a lot of adulteration with fentanyl in methamphetamines. So I think she needs to be educated about that. And it would be a good idea if she had naloxone, which ties into the next part of things, because I happen to know that you're up north, right? You're in Coas?
Yes.
Okay, so the Keene Serenity Center has naloxone available, and that might be a way that she could also get connected with some supports.
Mm-hmm.
So
Lindy, did you say Keene?
Keene Serenity Center, yeah, which is the Coos County. I don't know where is she, or where in the, is she close enough to Littleton to get there?
Yes, yeah. And we do have the Serenity Center in Littleton as well.
So they have naloxone. So that would be a way kind of to get her there, with just knowing that if she's going to continue using methamphetamine, then she really ought to have that in case there's fentanyl in it. I believe that they actually do have some in person, because they have a very large building. And so they're able to do some things with social distancing safely. So I would suggest that as a connection. And then also for the transportation and communication, is she connected with the doorway at all?
She has been in the past, and a lot of the we're providing a lot of similar services as the doorway too, with communication. We're tapping it. There's some challenges between our program and the doorway. However, we refer people to the doorway all the time. So while she does have access to them, I don't know that she has followed up with that.
Okay, so if she meets their criteria, and the fact that, is she still engaged with MAT with you?
Yes.
Okay, so even though she's not currently using the opioids, she qualifies for their flex funds, and that can help both with the transportation and maybe even potentially with getting more data for her phone, or some other communication access.
Yeah, I think we might be able to access that through the, yeah, absolutely. Thank you. Yeah.
So building off of Lindy, and if we're stumped on stimulants, which we sometimes can be, they are tough, that is for sure. Other questions of ways to help client develop sober supports, excuse me, and natural and resources with a stay-at-home order, and then resource and programmatic supports for transportation. We did get a chat in that said Courtney Martian is a great resource. She oversees the Merit program, which offers treatment and recovery services for individuals in Hillsborough County struggling with methamphetamine use. Can someone speak more about the Merit program? Is it available only to individuals in Hillsborough County? Is it offering any remote options at this time? Does anyone know? Perhaps we will have to follow up with Courtney. Thanks, Michelle. So we can reach out to Courtney directly and see what other points of contact she might have throughout the state. All right, other ideas and resources for Jennifer. We have another note from Anne. Where she has had a change in stability, it may be helpful to reassess her using the ASAM criteria to determine the level of care that might be most appropriate for her. Some of the IOP and PHP programs are providing services if it turns out that that level of care is more appropriate for her. Have you gone down that route, Jennifer, of kind of doing a full reassessment for level of care?
Yes, and I absolutely agree. She is definitely at a higher level of care. The challenges with that are definitely her transportation to the IOP and PHP programs. We don't have any PHP in the North Country, and the closest IOP that she would have access to would have been the Friendship House, which is closed. It's probably reopening, and so that's something we're going to relook at that time. Honestly, in my assessment, I really feel that she reaches the level of residential inpatient at this time, which she's not really willing to consider. But plant a seed and hopefully it'll grow. But yeah, she's hopefully our IOP programs up here will reopen very soon. And if anybody in the North Country wants to do a PHP program, that would be fantastic.
Do you have any concerns about imminent danger for this patient, Jennifer?
I do. And I mean, yeah, absolutely, quite a bit. You know, absolutely she is using regularly. I assume that she's using a lot more than she's telling me, and that she's greatly influenced by what's going on with her boyfriends, and I, you know, ex-boyfriend in quotes, because clearly there's a lot of relationship that's going on there. The relationship is very controlling and abusive, although she's not quite to the point of being able to say it's abusive. She's saying, no, it's mutual. So I have a lot of imminent danger concerns with her. She is, so I'm not her only point of contact here. Our case manager also, she speaks to very regularly. And so we've talked with her about her imminent danger and trying to get her assistance, and have talked about inpatient. There's also recently opened in Littleton a sober home for women. We've talked with her about that. I've talked with her about you know, supports for domestic and sexual violence, so the Birch House, which provides that, and a shelter. And so at this time, she's not responding. Well, she's responding to those things, but she's not quite to the point of seeking those out, or allowing us to help her seek it out, really.
And does she share with you what's holding her up at this point?
She does. And I think that there's only so much that she's able to identify herself. You know, I mean, she's able to identify that she has barriers and that there's reasons, but obviously there's underlying issues that are going on that she's not in a position to have. Well, she doesn't have the insight yet to really own that stuff. So we're kind of, you know, working on a lot of motivational interviewing to help her get to a point of being able to, you know, see that her goals and her needs kind of align with a higher level of care. However, also challenging because her attendance is, you know, she's using, so her attendance is very inconsistent.
And what has she said that her goals are? You said that, you know, her goals are maybe more in line with a higher level of care. What are those? Is she interested in abstinence?
She is. She's interested in abstinence. Her main goal is to have her son and to get her son back. And she would, you know, she wants to work. She wants to have a stable home. You know, so these goals and what she's doing are definitely not aligned right now. And I think part of her, you know, having difficulty meeting that is also because she's actively using, so her thought process is very skewed. And so, you know, she's very impulsive at this moment, and she's very much involved in that using process. And so the long-term goals are not holding the sway that they would if she wasn't using.
Yeah. Oops, I'm on my wrong screen. I gotta scroll up on our chat. Lindy had meant North Country Serenity Center, not Keene Serenity Center. That's okay, thank you. And then Molly has sent a study in the chat that we'll pull out and capture for you on mirtazapine, is perhaps how that would be pronounced. Molly, do you want to go ahead and share your findings and once you were able to locate the thread?
Yeah, I didn't reread I didn't reread it. I remember reading it. My impression was, wow, it may be something that I would consider trying. So mirtazapine is an antidepressant. One of the things I do know about methamphetamine is that it's not recommended to use SSRIs. They don't seem to help a whole bunch. But you know, for somebody who you think is depressed, but perhaps Remeron the brand name is Remeron for mirtazapine, and may have some benefits to the person on using methamphetamine. That was the first. I wrote another post, and that was the first post. Somebody actually just posting it on the chat that I was reviewing. There were probably 20 more posts, including those for those of you who know Mike Miller, long, loquacious discussion. And he will always come back to, though we all say, oh, this is so impossible to treat, it's not impossible to treat. There are psychotherapeutic strategies that will assist this person. She's motivated. I think, you know, we need to match, as Anne suggested, match level of care with her level of illness. And methamphetamine will boost dopamine higher than anything in life, and everything just falls to the wayside. And so for someone saying, you know, you'll feel a lot better, you know, you can't lie to them that it won't make them feel better than methamphetamine makes them feel. And so really it's just preparing somebody, saying, you know what, we need to do whatever we can to help you. That's the matrix model. It's, you know, kitchen sink. It's a lot of treatment. It's a lot of mutual help. Maybe it's some time away in a facility where she will receive a ton of support, and you know, still have the option to leave, of course, but maybe being reminded of her goals, and really helping her to reintegrate into the life of her family, and you know, finding joy in life again. You know, these are tough times too. I mean, looking at the whole COVID thing, I think can really send people who normally don't have depression or dysphoria into that sense of dysphoria and depression. So yeah, so there may be some benefit to mirtazapine. The other study that was on there was with N-acetylcysteine, which is an over-the-counter medication, looking at if it works on the I can't say the word, glutamatergic glutamate system, which also figures into the brain components of and the neurologic components of addiction. Those are not specifically studied for this yet, but some people just were saying anecdotally helpful. Remember, N-acetylcysteine is used when people come in with Tylenol overdoses, and the goal is to keep pumping it into them till they throw up. So it is a medication that can really cause some GI distress. So being careful with that, but that's a potential medication to try as well, if we're all looking for the magic pill, but there is not one. So.
Thanks, Molly.
Thank you.
Any other suggestions or resources to share with Jennifer, or Jennifer, any other questions for the group?
No, almost done.
All right. Hannah, could you pull up just the last 2 slides of my PowerPoint, please? Just gonna kind of give you the spiel, the overview about your evaluations and your CEUs, as I like to do. So as I mentioned at the beginning of the session, we have 2 CEUs and CNEs available. And if you attended our last remote community of practice, you will know that we have a new evaluation process for those things. So where I would be pointing to Melissa in the back of the room and saying that she's not going to let you leave until you hand her your evaluation. I don't have that kind of muscle power anymore in this remote format. So all I can do is send you an email tomorrow and ask you to please fill out your evaluation. After you complete your evaluation, you'll be automatically redirected to a Google form, which will ask for your name, your credentials, and your email. And then it says that your certificate is going to be emailed to you within 24 hours. It's actually pretty instantaneous. But I say 24 hours, you know, in case there's a holdup, and then you let us know, and we'll work to remedy should you not get your certificate. When filling that out, just make sure that you do put in your name and your credentials as you want it to appear on your certificate, or else you will get a certificate generated that just has your credentials, or, you know, whatever you type in there is going on your certificate is what I'm trying to say. So thank you all for attending our meeting today. Please continue to use the Google group for discussions and event sharing. I know that we've had a lot of resources shared through the chat today, so we'll be aggregating those and sharing them out through the Google group. I just got a message that we're going to get a couple more via email following up this meeting. So I'll be sure to disseminate those out to everyone. But thank you for your time, and, you know, be safe and well out there, and enjoy some sunshine with your families and as is safe. And thank you all again. Have a great evening. Bye, everyone. Melissa, will you save this chat again?
Addie, I think I've saved the chat, but just give me a second. My VPN is not connected.
A minute until recording.